talk about protocol quite a bit in EMDR. And something that I like to break down for my students in training is there's really 4 ways the word protocol is used in EMDR culture. When we talk about the standard protocol in EMDR, what that generally means is the 8-phase protocol that Dr. Shapiro conceptualized and published in her texts. The 8 phases are, of course, client history, preparation, assessment, desensitization, installation, body scan, closure, and reevaluation. And if you've gone through EMDR training, you ought to know the 8 phases very well. But the 8 phases really do happen inside a broader 3-pronged protocol to which Dr. Shapiro refers. And that's this whole idea of past, present, future. That the purpose of EMDR is to clear out past disturbance so as to improve present and future functioning. But then you also hear people talk about the protocol, and are you following the protocol when you get into the setup in phases 3 through 7, because that is what kind of a lot of people traditionally conceptualize as EMDR, because that's setting up the trauma processing. And of course, those of us who train have strong feelings about correcting folks that yes, phases 1 and 2 are part of the protocol as well. But phase 3 through 7 gets into this idea of setting up the target, asking a certain series of questions to activate the target, then desensitization, installation, and so on and so forth. And that follows 11 steps. So kind of even introducing another set of numbers. In Dr. Shapiro's text, she talks about the 11th step targeting sequence. So that's kind of an even more finessed understanding of the protocol within the 8 phases. And then you have these specialty protocols that really seem to generate a lot of buzz in EMDR land, like the Detour or FSAP protocols for addiction. It seems like every week, maybe I'm exaggerating, but at least every month, somebody in the EMDR community seems to be coming up with a new protocol.
Yeah, I see a lot of people asking questions in the discussion group on Facebook about different protocols for addiction or for OCD or for chronic pain, all these different protocols. And I'm just wondering where that fits into the protocol of EMDR in that broad text and then the smaller ones that we just talked about.
Sure, yeah. Is there a protocol for this? Is there a protocol for that? Is there a protocol for that? And on one hand, I want to be very clear that it's never my intention to disparage innovation. And I also understand that some adult learners work really well from having a really clear script ahead of them. So like when I'm working with addiction, these are the steps I follow, and so on and so forth. But my standard smart aleck answer when I see those questions posted in a lot of the discussion boards is the standard protocol is really what you need. Because if you learn the standard protocol well, and you learn the 11-step targeting sequence well, you can point the EMDR reprocessing any direction it needs to go. If you understand that phase 2 preparation is wide open to interpretation, then you realize that you can bring in any skills into phase 2 that can meet the population group that you're working with. So I really believe that a lot of these specialty protocols that are out there and marketed and given in training courses and published in articles really have their origins in the standard protocol. They're just different twists and turns on the standard protocol to kind of allow for some different modifications. And one of the reasons, for instance, in my training program that we don't teach any of the specialty protocols in the basic or the standard training is I believe the point of standard training is to get to know the standard protocol very well. And then once you do, you ought to be able to pick up like a scripted protocols book or an article on any of these specialty protocols and really know how to adapt them if that's what in fact you need. But I will tell you, throughout my EMDR career, I have rarely used any of the specialty protocols. I've tried some of them, and all of them just kind of strike me as this is just another way to do the standard protocol with a spirit of modification. And I do think a spirit of modification and adaptability is what you need to do good EMDR with complex trauma, dissociation, addiction anyway. So if you understand that and the spirit of adapting EMDR, but you do it with that strong grounding in the standard protocol, you really have everything you need to be able to apply EMDR to just about any clinical population.
So kind of speaking of standardized protocols and kind of adapting those for specialty populations, I know some of the questions I see a lot too is how to work with people with really complex trauma who tend to dissociate or freeze, especially when accessing really emotionally distressing content or memories.
The key there is that one calm, safe place exercise is not going to cut it when it comes to preparation. And I know when I was trained, the calm, safe place was really kind of emphasized. It's seemingly one of Dr. Shapiro's that she writes a lot about in the text. And I'm very grateful that I kind of came of age when there was more of a push to recognizing that we need more in phase 2 in preparation than just a calm, safe place. We need more than container. And I will say that in our training program, I give people what I call the big 3: calm, safe place, light stream, and then container. But I also tell my trainees, I could probably spend 3 extra days with you just going over skills that you can learn in phase 2. And indeed, I believe anybody who's doing EMDR has to have a battery of skills in the area of grounding, breath work, body movement and somatic exercises, expressive arts, and more than just visualization, use of all the different senses like texture and touch and scent. And speaking of texture and touch, you may hear a kitty in some of these videos. So yeah, phase 2 really needs to involve an understanding of what it even means to ground. And phase 2 needs to involve what skills can I give this individual so that they can handle what may come up. And that's where I believe that a lot of these questions that you see posted and that I get about, what about a protocol for this, protocol for that? What I really seem to be hearing is a cry for, how do I get these folks ready? Is there something I need to know to better prepare, let's say, a dissociative client before they can handle going into trauma reprocessing?
So what I'm hearing is that a specialized protocol for someone who is dissociative might be just a more built up phase 2 with a lot more resources and versatility for that client.
Yes, so a built up phase 2 with resources and versatility, and also an understanding that the more complex the trauma you work with, the less likely you are going to be able to get a really neat chronological history. Kind of flowing from ages 0 all the way up to the present. Or I know there's a popular method for history taking in EMDR, like what are your 10 worst memories, your 10 best memories. And I find that even listing those can be a little activating or flooding for somebody who comes in a little crispy with, I don't even know if I want to go there just yet. So obviously you may need the more robust phase 2. But in addition, it's kind of taking history in a more thematic way, as opposed to a more chronological way. So for example, when I work with addiction quite a bit, I'm rarely, if ever, setting up a phase 3, phase 4 targeting around the first earliest touch tone memory of trauma itself, even though conventional logic in EMDR may suggest you go back to the earliest. But for instance, I work quite a bit with recovery roadblocks first. So if a person is struggling with, I cannot cope with my emotions without alcohol, we may use that as a blocking recovery theme, as a negative cognition, and then float that back, thinking back over the course of your whole life. When is the first, the worst, the most recent time? And when you take history that way and you assess client readiness that way, you're able to start working on targets in an order that they may be able to better handle them, and in a way that may feel more relevant to what's happening in their recovery right now. So I think where a lot of people think the standard protocol fails complex trauma is if they're really doing it in a very kind of by the book, go back to the earliest touch tone way. Of course you're going to need to modify it. And even something I understand as a trainer is that we do have a lot of permission, and I feel that Dr. Shapiro even gives us this permission in her text to take client history in a way that may be appropriate to the client. Hello. These cats always make these videos much more fun.